Yes.
Dr. Gillon, we're going to try and look at the SNBTS Directors Meeting minutes from the 3rd of March 1987, PRSE 304163, please. We can see the date there at the top, and we can see underneath the heading Introduction and Apologies for Absence that you only attended for certain items. I don't think you attended for the point we're going to look at. But as I said before, I just want to go to it to have some context for my subsequent questions. Could we turn then to page 5 of the document, please, Paul? We can see there the heading Surrogate Testing for NonA, NonB at the bottom of the page. The UK Working Party on Transfusion-Associated Hepatitis had been reconvened to pursue the issue of implementing surrogate testing for NonA, NonB. A proposal for a study which would include the Glasgow and Edinburgh transfusion centres had been modified, and no Scottish centre was now being asked to participate. And if we go over the page, it was noted that some commercial plasma collectors and non-profit blood collectors in the US had begun surrogate testing in 1987, and that in Britain the Haemophilia Society may adopt a position which put pressure on BPL to ensure surrogate testing was introduced. The directors discussed the options open to Scotland and agreed the following: to recommend to the SHHD that surrogate testing for NonA, NonB should be implemented with effect from the 1st of April 1988, as a national development requiring strictly new funding. Each director should let Dr. Cash know what funds would be required in his or her region, assuming that both core testing and ALT would be undertaken in the transfusion centres. It was noted that research was being undertaken into a combined core surface antigen test. So that was the position of the directors of the SNBTS in March 1987. Were you aware of that position being taken by the directors at the time, Dr. Gillon?
Maybe not in advance of that meeting, but certainly fairly soon afterwards, I think I came to know about that.
And then in 1988, you published a study in the journal Vox Sanguinis. Could we put that up, please, Paul? PRSE 302655. We can see it's headed Post-Transfusion NonA, NonB Hepatitis, Significance of Raised ALT and Anti-HBC in Blood Donors. And then if we read the abstract, the FDA has recommended that all blood collected in the USA should be screened for antibody to hepatitis B core antigen and for raised alanine aminotransferase as possible indicators of NonA, NonB hepatitis carriage. As part of an assessment of the medical and economic implications of such a screening programme, we've screened 1,742 regular blood donors for ALT and 2,086, including the same 1,742, for anti-HBC. 42, 2.4%, of the 1,742 donors had ALT levels above 45 units per litre. Clinical assessment of 33 of these revealed that 26 exceeded their ideal body weight by more than 10% and 15 by more than 20%. 11 admitted to an alcohol intake of over 40 grams daily. In all, 82% of donors with raised ALT had a non-viral clinical explanation for this abnormality. Anti-HBC was detected in 42, 2%, of the 2,086 donors screened. 27, 64%, also had anti-HBS, the surface antigen, and 11, that's 26%, had anti-HBE. There was no overlap between donors with raised ALT and those with anti-HBC. Combined screening would lead to a loss of at least 4.4% of donations in the population studied. In view of the medical and economic implications of the introduction of these screening tests and the poverty of data on the clinical significance of post-transfusion NonA, NonB hepatitis, we conclude that such a screening programme cannot be justified at present. further studies are required, including a prospective controlled trial of the effects of screening. Dr. Gillon, just picking up first that last point of the poverty of data on the clinical significance of post-transfusion NonA, NonB hepatitis. This paper was obviously in 1988, and Professor Preston's work in relation to cirrhosis and significant progression of liver disease was published in March 1982. Can you help us then with what you were meaning, what you were referring to there when you talked about the poverty of data on the clinical significance of NonA, NonB?
I think there was a relative poverty of data. Apart from Professor Preston's work, there certainly wasn't a huge amount of detailed data on, for instance, liver biopsy is the essential investigation there, which is a very invasive test to do, particularly in haemophiliacs. And it was a wonderful piece of work he did to show that. But I don't think there was a huge amount of work on other groups of patients that I can remember. Certainly that must have been my impression at the time to have written that.
And by other groups of patients, are you distinguishing the possible effects of NonA, NonB in someone who's had a transfusion rather than a haemophiliac who's received a factor concentrate?
Yes, I mean, I suppose there is a possibility that you could have an agent which, because of the quantity of transfused material, would be more damaging to haemophiliacs than to somebody just having 1 or 2 units of blood. And of course, it hadn't been established without doubt that there was an infectious agent involved. So I guess that was the thinking at the time, my thinking.
So even in 1988, you were, is this fair, you were hesitant to accept that NonA, NonB was anything more than a benign condition?
Not universally, obviously, because the the biopsy data were really incontrovertible from the haemophilia studies. But I wasn't aware of it being a problem in any other setting to anything like the same degree.
Moving on, in relation to the point raised here, where you say, in view of the medical and economic implications of the introduction of the screening tests, if we carry on through the paper, I just want to pick up 2 parts of the discussion. Page 4, please, Paul. And picking up in the first block of text, it's important for those who advocate. Thank you. It's important for those who advocate ALT testing to recognise that this tendency to fluctuation in ALT levels would produce a cumulative loss of donors far in excess of that suggested by studies already published, and that most of these donors would not be NonA, NonB hepatitis carriers. It carries on, and then you indicate combined testing would lead to an initial loss of 4.4% of donations. Just dealing with that part of your discussion of the implications of the screening being introduced, a 4.4% drop in donations. It's right, isn't it, that that was less than the percentage drop that the service had experienced from the declarations required on the AIDS forms?
Yes, that's true. But you need to appreciate that it's an initial loss of 4.4% of donations. If you then have to replace that loss of donors with new donors, they would then be screened and they would produce the same sort of percentage loss. And therefore it becomes an accumulation of loss upon loss upon loss to maintain your donor population. And I think that was not sufficiently appreciated at the time.
It wasn't sufficiently appreciated by whom?
In any of the other writing about it very much. I do remember that in one paper, Harvey Alter did refer to it, but I felt that not enough attention was paid to that you're then bringing new donors into the system to make up for those. New donors, as we know, are much more likely to have infectious agents in a percentage of them as a population. So it's not an absolute contraindication to doing it, but it's something that needs to be understood and appreciated before you get into the situation where you've got an accumulating loss of donor.
And then on the second column of the same page, we have this point which you raise in your discussion. You've discussed some of the potential benefits, and you say, nevertheless, if we were to assume that this degree of benefit's achievable, the blood transfusion services in the UK would be required to test around 2.5 million blood donations each year at an estimated cost of £2 to £3 per donation, an annual bill well in excess of £5 million. In addition to this raw cost of screening all donations, account must be taken of the clinical consequences of identifying up to 5% of the donor population as being potential carriers. The assessment of each of these donors with further laboratory testing will generate substantial costs. If the blood transfusion service were to take the same responsible attitude to the medical assessment and counselling of these donors as it has to HIV antibody positive donors, staff and resources would be required to deal with 4 to 6 donors daily in a medium-sized centre. At least as important as the financial consequences of combined testing is the potential morbidity generated in these donors as a result of informing them of these abnormalities. Our experience in this study has convinced us that such donors suffer significant anxiety, though it could be argued that the identification of obesity, alcohol abuse, and perhaps significant liver disease could be of potential benefit. So in relation to that implication of introducing surrogate testing, why would that not be a relevant factor for the donors to be receiving medical care that they potentially needed?
Well, no, I think I acknowledge that in various categories there, it might well be to their benefit to have that identified. I was just making the point that the context is important, that you inevitably are talking to them about potential liver disease which you cannot establish a cause for and cannot be sure about. And that in itself is a cause, I think, a cause for anxiety. It was a complicated question. I was trying to see both sides of it, and the pluses and the minuses. And the main purpose was, of course, to try and assess what sort of impact it would have on those donors. Rather than, it was coming at it from a donor perspective rather than a patient perspective at that stage.
Dr. Gillon, you've preempted my next question. How much consideration was given to the impact that screening would have on recipients when you come to your conclusion that a screening programme couldn't be justified?
The question of how much impact it would be on recipients cannot be answered from those kind of data. The data weren't designed for that purpose. So I don't think writing that had any particular view about how the question of surrogate testing should be addressed in terms of the recipients.
In fact, no surrogate testing was actually introduced in Scotland, was it?
No, that's correct.
Could we put up paragraph 176 of Dr. Gillon's witness statement? It's on page 67. You've said that an important point to consider is that introducing these tests would have no impact on fractionated products, such as factor 8 and factor 9 concentrates, which were produced from pools of plasma of around 4,000 donors. And you've said heat treatment of factor 8 was introduced in late 1984 and heat treated factor 9 in 1987. I think, Dr. Gillon, you wanted to make a correction to that paragraph of your statement.
Yes, that's correct, because it was a memory failure on my part. I wrote that from memory, and a former colleague got in touch, in fact, two former colleagues, by email just 2 days ago, after the statement appeared on the website, to point out that factor 9 was in fact heat treated from 1985, which I had forgotten. So I do apologise for that, and I hope you've received the suggested new wording of the paragraph which I provided.
And that was simply to change the dates. In fact, in relation to factor 8, although heat treatment was introduced in late 1984 in relation to HIV, the Scottish factor 8 heat treatment in relation to hepatitis C was only effective from April 1987, is the evidence that the inquiry's heard prior to this. So it puts it at a little bit of a later date.
That's true, but I was trying to make the point that by 1987, which was, referring back to the question, it was being discussed in 1987, by 1988, in terms of patients receiving fractionated products made from large pools, would have no benefit from it, in fact.
And just finally, in relation to surrogate testing.
Well, before you do that, may I just ask, the figure of around 4,000 donors, that was your understanding. Now, you may have to ask yourself whether this is recollection or whether it's accurate. But that's your recollection of the pool size, presumably that the PFC in Liberton were using, is it?
Yes. I can't remember. I think that was something that I took from an answer I had provided to the Penfold inquiry. But I'm not entirely sure where I got the 4,000 number from.
That would be... Sorry.
Sorry.
Sorry, I interrupted. My apology.
Sorry, I was just going to say, I think I did check that at the time. It's such an unusual number that why 4,000? Looking at it again, I asked myself the same question, but I'm not sure what the answer is.
Well, you do say around 4,000, so it'll be, it's a there or thereabouts type figure, but it's that figure rather than something bigger, 6,000, or smaller, 400. So it
certainly was nowhere near 400, and it may well have been a lot closer to 6,000.
Yes. And that had been a figure which, as far as you knew, had increased, had it, over the years?
I really don't know.
You don't know. Very well.
Hepatitis C screening, we know, was introduced on the nationally agreed date of the 1st of September 1991. But it's right, isn't it, that the SNBTS had been involved in testing screening kits before that date?
Yes, that's right.
But you didn't have any particular input into that or the date of implementation of screening other than one paper where you'd looked at some first-generation screening tests. Is that right?
That's correct, yes.
Your involvement was primarily concerned with donors who tested positive and the look-back process.
Yes.
Can I turn then to PRSE 304689? This is a letter from Professor Cash to you on the 21st of June 1990, headed Donor Counselling HCV, and we can see this. The SNBTS directors believe it's now very important that UK BTS prepares itself for the commencement of full anti-HCV donation screening. As part of this exercise, they believe a high priority should now be given to producing operational guidelines for BTS doctors or other doctors engaged by the BTS in the context of counselling anti-HCV confirmed positive donors. Included in such guidelines would, of course, for the SNBTS, be the facility for onward referral to specialist clinical teams. Looking at the position today, now that we know we will have access to confirmation testing, we're now placed operationally in an almost identical position as with HIV-1 testing. It may be identical by the time we start. The directors would be most grateful if you chair a small group that included Dr. George Gallier and Dr. Bob Crawford and come up with an appropriate first draft guideline for consideration by the directors on August the 14th. I'd also be most grateful if you would keep Dr. Harold Gunson in touch with your activities, as we'd like to see as much harmonisation north and south of the border as possible. You agreed to do that, Dr. Gillon, is that right?
Mm-hmm. Yes, that's right.
And the group produced an idealised procedure?
Yes, which was indeed based on what we had done for HTLV3.
If we could turn to PRSE 40515, please. We have a copy of the recommended procedure. It's dated the 23rd of November 1990. And we can see this. The following is an idealised standard procedure for managing anti-HCV positive donors. It should be seen as a guideline to providing a reasonable standard of care, but it's acknowledged that for practical reasons, the procedure may be adapted to local circumstances without jeopardising the standard of care. The document then deals with the initial positive tests. Then if we go over the page, we see under the heading 3 what is to happen in relation to donors with a confirmed anti-HCV positive on the second sample. So the confirmatory tests have been completed. At 3.1, on receipt of the repeat results, provided they confirm the donor's seropositivity, the donor is informed and advised on the need for further investigation or follow-up. The donor consultant decides on the need for specialist referral or follow-up based on the epidemiological features and results of liver function tests. The donor's general practitioner is informed by letter with the donor's permission. In the case of regular donors, the fate of previous donations is determined and look-back initiated in accordance with SNBTS policy. Just pausing there, when it refers to look-back being initiated in accordance with SNBTS policy, what were you referring to there?
Well, that is a presumption. The presumption being that from the very first draft of these guidelines, we as a group, that is 3 donor consultants, and the only other person in the group was Dr. Jan Davidson, who was one of the doctors working with me in the donor centre in Edinburgh. And we had agreed on the draft of this proposal that we should look back in exactly the same way as we did for HIV.
If we carry on to the next page, we've got the report that went with the procedure, the report of the working party. And as you say, Dr. Davidson is also noted as a member of the working party. If we then carry on to page 6, please, Paul. We see this in relation to look back. The group discussed the question of look back. Donors may well ask about the outcome of their previous donations, and a clear policy on look back is essential. We note the logistical difficulties which have been taken as justification by the AABB for not recommending a look back. But our view was that this position is untenable in view of the desirability of informing recipients so that they can protect others and also receive treatment with interferon if the benefits of this form of therapy are confirmed. That was the recommendation of the group, as you say, that look back would be instigated. Once this report and recommendation was produced by the working party, can you tell us your understanding of what happened then in relation to the question of look back?
The first thing that happened was that it was discussed by the directors, I think in November of 1990, and endorsed, and the inclusion of look back was part of that. Then I think there was some movement in February, and there was some discussion to make sure everything was set up for the introduction of screening whenever it was going to be. And discussion among the directors, which, as far as I know, accepted that this would be part of the process. But then out of the blue, I can't remember exactly now when it was, sometime after that, I had a letter from Dr. Cash, more or less saying that we weren't including look back as part of SNBTS policy after discussion with Dr. Gunston. And I was extremely unhappy about that and discussed it with Dr. McClellan.
Just before we get there, Dr. Gillon, can I just pause you and explore one point?
Sure.
You've said that Professor Cash told you that look back wouldn't be happening, and in your witness statement you've said that you were told in February 1991 that this was because of it was in light of national events.
Yeah.
Were you ever told what those national events were?
No, I still have no idea.
Were you given any more information than simply that phrase, in light of national events?
No. I discussed it with Brian McClelland, and he couldn't enlighten me either. Obviously, he had been present at the directors' discussions. So I assumed it was something that had gone on between him and Harold Gunson, but it was kept in the dark.
You were about to tell us that you were very unhappy with that decision. Why was that?
Well, I could see absolutely no justification for it. And to say that we couldn't cope logistically with did not ring true to me. If it was shown to be the case that there was a high prevalence of hepatitis C, then the proper procedure would have been to apply for the money to hire extra staff if that was necessary. But to rule it out on that basis just did not make any sense to me at all. And we had no idea what the prevalence was going to be. And we had coped perfectly well with HIV.
At that point in time, Edinburgh also held serum samples back to 1984. In your opinion, what would standard professional practice have been in relation to those samples if once screening was introduced?
Do you mean in terms of look back?
In terms of look back.
In terms of look back, well, as I explained earlier with HIV, that would have been very useful in establishing when the donor had been become infected or seroconverted. which might have limited the damage as far as workload was concerned, but might not. It's quite possible some would have had it right back beyond 1984, quite likely. I'm not entirely sure what you're getting at. Are you meaning that maybe we should have tested all of those samples?
I was simply referring back to what you'd said about the HTLV3 look back, where you had tested the serum to identify when people had seroconverted, and whether that would, in your view, have been the appropriate approach in a look back in 1991 as well.
Yes.
You've said in your statement you considered it to be unethical to fail to inform recipients of previous donations. Can you unpack what your concerns were in relation to that?
The main thing, I think, is for the individual recipient in terms of disclosing to them that they have a condition which is potentially serious. And although there is no available treatment, it's something that is certainly worth looking further into and getting expert professional advice and follow-up. In the event that treatment did become available, then they would be known about, they would be first in line for treatment. And the second consideration was that if we didn't tell them, they might then pass it on to others, particularly sexual contacts, obviously. And it seemed to me that combined with the fact that we had accepted across the Western world that that's what we should do when we introduced HIV screening, there was no logic in saying that we shouldn't do the same for hepatitis C patients.
So you'd been told by Professor Cash that it wasn't, a look back wasn't going to be undertaken. You were concerned about that. What did you then do about those concerns?
I spoke to Brian McClelland, and Brian was sympathetic. He supported me and offered to speak to John Cash, which he did. And at some point, one of them, it certainly wasn't me, but one of them suggested the idea of calling it I had said that, you can say we're not having a policy, but I'm going to do it for the patients in Edinburgh and South East Scotland, which put the ball very firmly back in John Cash's court. And he, I think must have been he who came up with the idea of calling this a pilot study, which was fine by me. He could call it what he liked as long as he understood that I was doing it.
Because, as you said in your statement, you'd effectively said in no uncertain terms that you were going to do it anyway. And the pilot study was perhaps just a badge of what it was. Is that fair?
Yes.
That pilot study took place between the 1st of September 1991 and the 29th of February 1992. What happened from the 29th of February 1992 through until the start of the national look back in April 1995 at the SNBTS in relation to look back?
The, in inverted commas, pilot study continued because, of course, it wasn't a pilot study. It was standard practice as far as I was concerned.
So the official pilot study had a time frame attached to it, but you continued to undertake look back all the way through the period.
Yes, it wasn't entirely an arbitrary choice to make it the first 6 months, because when you introduce a new test, what you get is you kind of clean up your donor population by identifying within the time period when the majority of your donors will have donated, which could be around about a year. You'll have picked up most of all of the positive new donors in that period, but also the large majority of your regular donors as well who are carrying the virus. And it was a practical thing. I thought it was time to put it into the public domain and see what happened.
Just before we look at the paper that was published, can you help us with this? When you undertook the pilot study, were there any difficulties that you faced in tracing recipients?
There were the usual difficulties which we discussed earlier, which is that it can be very difficult to establish where a unit of blood or a component went and what happened to it. And in this case, of course, the problem had been around for a lot longer than the HIV problem when we started screening. We had at least 10 years worth of accumulated problems, if you like. And we really didn't have a good idea until at that 6 months point we looked at the numbers and saw that in fact the prevalence in the donor population wasn't nearly as high as people had been talking about. It was less than 1 in 1,000 overall, which was perfectly manageable. It didn't make it any easier tracing the various components. It was still significantly higher numbers than with the HIV look back, but it was manageable.
So you've indicated there were difficulties in knowing what had the end result of the blood component, who had received it, what had happened to it. Even once you'd identified a person who had received the blood component, did you face any difficulties in then identifying and finding that person?
Sometimes, yes. People moved, they moved house, got married and changed their surname. It could be difficult tracking them down. The system for tracking patients through the GP system was in its infancy at that stage, but it was improving. And there were ways of identifying where a known person was registered to a given GP. But it was rudimentary at that time.
And then if we have a look at PRSE 301046, please. We've got a paper that you wrote together with Dr. Ayub in the Transfusion Medicine in 1994. Risk of hepatitis C in patients who received blood from donors subsequently shown to be carriers of hepatitis C virus. And if we just look at the summary together, a retrospective study was undertaken to identify recipients of blood from donors subsequently shown to be positive for hepatitis C virus using second-generation tests and polymerase chain reaction. The main aims were to determine the numbers of such recipients who were still alive and traceable, and to determine the risk of infection in this group. The feasibility and workload of this procedure, which is currently not practiced in the UK or USA, was also assessed. In the first 6 months of routine testing, 42,697 donors were tested. Of 20 confirmed to be HCV positive, 15 were regular donors. 83 components were prepared from 63 anti-HCV positive previous donations from these donors. In all, 9 recipients were found to be alive. All positive for anti-HCV. We conclude that although this retrospective procedure is time-consuming and difficult, substantial numbers of infected recipients can be identified. The availability of treatment for chronic hepatitis C for such patients should encourage transfusion services to reassess current policies on the hepatitis C retrospective. And then if we continue to page 4, which is the discussion section. And in the second column, you say this: our experience confirms that the identification of these patients is a daunting task. but the availability of potentially efficacious treatment for chronic hepatitis C in the form of alpha interferon compels us to suggest that we have a clear ethical responsibility to these patients to identify them and offer counselling, testing and, if necessary, treatment. Many of these patients will be old and most will have only mild liver disease, but it's our view that this problem should not be ignored on logistical grounds, when in each case there's an overwhelming responsibility to the individual patient. That was the results of the study in that publication. What was the impact, as you understood it, of the publication of those results?
They had come out in a sort of unusual way. I think I presented some of the data at a meeting at some point, either in early 1994 or late 1993. At any rate, it got into the blood transfusion community in the UK through the course of 1994. And on publication, well, I think there was some movement before the paper actually appeared for publication, and I'm not entirely sure from memory exactly how that happened. But there were discussions, and I hadn't appreciated this, but I do know from some of the other witnesses that you've had before you that there was a certain amount of anxiety about this throughout the United Kingdom, about the fact that there was no look back going on. And towards the end of 1994, an offshoot of the MSBT, the Committee for Microbiological Safety of Blood and Tissues, was set up. Well, I should know the exact sequence of this. You've probably got it in front of you.
We've certainly heard it before. I think I want to just focus on what you understood was happening. You'd presented this data just before publication, and then there was the publication of the results. Is it fair to say that these results from your pilot study acted as a significant catalyst to the reconsideration of whether there should be a look back across the UK?
Yes, I can certainly say that it had an impact in Scotland, because the Deputy Chief Medical Officer, Dr. Aileen Keel, was present at the meeting where I presented some of the data, I think early in '94, and she took it on board. She agreed entirely that there was a good case for doing a look back in Scotland. So it went to the Scottish office. It found its way, and I don't know if that was what the channels were, but at one point the Minister of Health in Scotland wrote to the Minister of Health for the UK or for England.
And were you kept up to date with that, or is that just your understanding subsequently?
I wasn't kept up to date in any formal way with that at all, no. I didn't know about it until I was invited to join the working party of the MSBT.
You were asked to produce guidelines for counselling patients with hepatitis C, and your guidelines were produced on the 17th of February 1995. If we could look at those, NHBT 302874_002, please. We can see that it's headed draft, transfusion-transmitted hepatitis C guidelines for counselling patients. And it goes through the implications of a positive test, the prognosis, the modes of transmission, then over the page, avoiding infecting others, and further assessment and follow-up, with a note for the need for a specialist to be involved. If we then go back to the first page, the introduction, we can see this. Transfusion services in the UK began screening for antibodies to hepatitis C on the 1st of September 1991. Patients transfused subsequent to that date have a negligible risk of having been infected by the transfusion. Not all of those transfused with potentially infectious blood prior to the commencement of testing will, however, be identified by the look-back procedure. The donors of the transfused materials may not have returned since September 1991. Thus, even in cases where the look-back has not implicated an individual patient, it may only be possible to provide full reassurance by offering to test the patient for antibodies to hepatitis C. At this point in time, February 1995, what discussion was there about how to approach this issue of recipients who wouldn't be identified by the look-back?
Very little, I think. It may have been referred to in the Working Party minutes, I can't remember, but it wasn't at the forefront of anybody's mind, I don't think. I think everybody felt that doing the look back itself to the point where you run out of information, more or less, was seen as the way to get it done up to that point. And I think it was felt that it was probably a bit premature to be thinking about that, and that the main thing was to get it started and get people looking and trying to trace recipients.
If we then turn to LOTH 5023_005, please. We've got notes of a meeting headed Hepatitis C in Scotland, notes of a meeting held on the 20th of October 1995. And against point 1, we see that you reminded the group that approximately 3,000 patients with HCV were anticipated from the UK National Look-Back Study, with approximately 300 in Scotland. He outlined the present situation with regard to the look-back studies. It carries on. Edinburgh were approximately halfway through tracing. Can you assist us as to why it was said that Edinburgh was approximately halfway through tracing in 1995, when the pilot study had been running since 1991?
I don't think I can, actually. No, I'm sorry. I don't really understand what that's referring to.
Because your understanding is that tracing had been going on since 1991 consistently. So as at 1995, it would be a puzzle why there would be a number of recipients still to trace.
So it was a continuing, ongoing process, and in a sense, there was no way of knowing what the whole thing was, other than that those were just the donors you happened to have identified and the patients you had tried to trace. But why we should only be halfway through is a mystery to me. I do not understand what that was referring to.
And just thinking about when you were tracing recipients who came to light in 1995 as opposed to 1991, were there any additional hurdles to tracing a recipient in later years than there had been in 1991?
Not really. I mean, more of them would have died. Already the number of 9 in 1991 of recipients traced as a result of, I can't remember how many donors there were. So it was in a way, disappointingly small. But the reality was that a fairly large proportion of the patients had died.
Is it fair, though, that if you add additional years before you attempt to look back, more recipients might have moved or married as well?
Indeed, yes, those problems would have compounded themselves, yes. And it did get more difficult. Maybe that just means that in theory we were halfway through, but in fact the reason that there was half of them not identified was that they would never be identified.
Just turning to the question of those recipients who wouldn't be identified because donors perhaps didn't return, could we turn to STHB 40687, please, Paul? It's a meeting of the SNBTS Medical and Scientific Committee on the 10th of October 1995, and we can see that you were in attendance for particular items. If we turn then to page 4, we've got the heading HCV, look back, update of SNBTS position. And if we go to Roman 4, with respect to recipients of blood components pre-HCV testing, the MSC agreed that testing of available donor archive samples would be neither cost-effective nor appropriate. So the committee appears here to be considering what to do about recipients of blood components who weren't caught by the look back, and there is this question of testing the donor archive samples.
Yeah.
Do you recall why it was felt that it would be neither cost-effective nor appropriate to test those samples?
You take the appropriate first. Although by then Edinburgh and all of the other Scottish centres had established libraries of frozen samples, we had started at different times, so it would be an uneven business. The cost side of it was going to be enormous. I think I calculated at one point that there was something like 2.5 million frozen samples in Scotland alone. The amount of work and time taken to identify all of those accurately, re-record them, thaw them, test them, was going to be enormous. And my back of an envelope attempt to get a handle on that led me to believe that it would take a whole new laboratory to do that work in Edinburgh alone, in any sort of timely fashion. So it was going to cost huge amounts of money, take endless amounts of time, be incomplete because some libraries of samples were bigger than others. There were, of course, that library had already been dipped into and samples taken out for other purposes, and probably used up because these were tiny samples in sort of microtubules. So it was going to be enormous, difficult, very costly, and incomplete.
Just in terms of your first point, that it would be uneven because different people had different libraries of samples over different periods. With the benefit of hindsight, would it perhaps have been better to have identified some recipients, even if not everyone in all years could be identified?
Indeed, yes. And that was only a relative contraindication, if you like. I think the youngest library in Scotland started in 1986, I think. So they were fairly substantial. collections in all of the Scottish centres.
And just carrying on with this document, the second bullet point, that an offer to test anyone who'd received blood components or products prior to HCV screening was likely to be the most effective option. What was your view of that suggestion?
My view is that it wasn't like to be a very effective option. But compared with the mountain of work and expenditure that testing all the samples would be, and the length of time it would have taken an enormous amount of time to do all of that. At least this would be a quick way to offer something to the people affected, even if it didn't catch all of them by any stretch of the imagination.
And if there had been an extensive advertising campaign, or let me rephrase that. What was your concern about the effectiveness of such a proposal?
Just that people wouldn't see it, wouldn't know what to make of it if they did see it. You know, if it was in a corner of a newspaper somewhere. I think I felt it would, I suppose, be a gesture, and maybe not much better than a gesture.
And then on this document we see that this latter option, the suggestion of offering tests to anyone, is noted that it shouldn't be pursued until the present HCV look-back exercise was substantively complete. In fact, it wasn't pursued at all until after the Penrose inquiry. Do you know why that was?
I think it just fell off the agenda. I don't remember a point where it was stated that we would not do that. But neither was it ever stated that we would.
Sorry, if we can just turn to SBTS 40463_081, please. At 40463_081. We can see this is picking up, just tying up the stored samples issue, Dr. Gillon, just for completeness' sake. It's a note from you in relation to HCV look back, noting that the Department of Health ad hoc working party would be discussing 2 possible extensions of the look back process, and you wanted to seek the views of the SNBTS on those issues. Under the heading testing of all stored samples, you note there that legal opinion in DOH and SHHD is that these samples should be tested and recipients of HCV positive donations traced. Was that legal opinion that you had sought or that it had been sought by SHHD?
I don't remember this this note, nor the discussions with at DOH and SHHD.
Just for those who are watching today, we can then see the 4 bullet points which pick up the points that you've made in your evidence today about the arguments against testing the stored samples. And then the second point on the page, which I just want to explore with you, is Dr. Ludlam has proposed that recipients of Factor 9 prior to 1986 should be traced. This will be extremely difficult logistically. Advice from the regions would be invaluable. Do you recall anything about those discussions, Dr. Gillon?
I'm afraid I don't. No.
can come down, thank you. And then a more specific issue in relation to cut-off periods of donors. Could we have NHBT 309732, please, Paul? If we start on page 4, and we'll work our way backwards. This is a letter from you to Mr. Ranald MacDonald, Senior Legal Advisor in the CLO, where you say, I'd be most grateful for your advice about a matter which was raised at the Specialist Advisory Committee for Transfusion-Transmitted Infections. A consultant colleague at the North London Transfusion Centre has been asked by a clinician who has responsibility for a patient with hepatitis C whether the donor of a unit of blood which the patient received in 1984 can be recalled for testing to try to establish the source of the infection. The donor hasn't donated blood for many years, and there was a general view expressed that it wouldn't be right for the transfusion service to attempt to contact a donor in such circumstances, particularly if, as is believed to be the case here, the outcome would be unlikely to affect the patient's treatment. However, an opposite view was expressed that we have a duty of care to the donor, and since there's a reasonable suspicion that the donor may be infected with hepatitis C, we owe it to him or her to bring this to their attention and offer testing and counselling as necessary. You then seek their advice. What was your view of this situation, of what should be done?
I don't remember it specifically. I suspect my view at the time would probably be that we should try to trace the donor.
Advice was given then that from Mr. MacDonald that the transfusion service shouldn't ask the donor to return, and then you pressed them because, in fact, if we go to the letter, it's page 2 of this document. You say the letter from the legal advisor had said, in the absence of a general practitioner, it would be acceptable to advise the donor in an appropriate manner of an infection which in the first place would pose a risk to later recipients of his donations, and secondly, that which may pose a risk to himself if untreated. You indicate that would describe the current situation, in which it's unusual for us to know the identity of the donor's GP, and we therefore contact the donor directly if one of our screening tests is positive, or if, as is rare, we identify a disease in the recipient which makes it likely that the donor has a disease requiring treatment. In the case under discussion, however, the difficulty is caused by the lapse of time between the donation and the identification of disease in the recipient. It may be that the donor is still harbouring the disease unknown to himself, but we're far from clear that our fiduciary duty to the donor would extend over such a long period of time. When donors have not given for 2 years, we consider them lapsed and no longer send them call-up cards. Would there be any justification for regarding this as the arbitrary cut-off point, beyond which our duty to the donor no longer pertains? That was your question. And the response from Mr. MacDonald was page 1. I don't consider that the duty of care to the donor extends to advising the donor of infections or possible infections which may be identified in his donation. Accordingly, there'd be no requirement to go back to the donor, except possibly as a matter of good practice. And he notes the use of the 2-year cut-off point as being a matter of good practice. Do you have any recollection, Dr. Gillon, of what how this situation was resolved?
I'm afraid I don't. I do recognise this letter, but I hadn't seen the previous two. No, I don't know what happened after that. So,
your letters to Mr. MacDonald were obviously trying to understand the legal position. From your own, from your own view, what do you think was the appropriate? What's your recollection of your view of what should have happened in this situation?
I think I I would have suggested going back to the donor, I think.
By not going back to the donor, what would the position be in relation to other potential recipients of that donor's donations? I'm sorry, Dr. Gillon, that was a very unclear question. Let me ask it in a different way. I
think really it's a question of policy or theory, which I can deal with, can't I?
Apologies, sir, yes. I've just got a couple of further questions to finish up on this. Could we just turn to PRSE 302209? Well, this document and one other, Dr. Gillon, before we take a break. We have here a document setting out the Scottish hepatitis C look-back results as at the 9th of April 1998. And we can see here the number of donors identified who'd given blood before 1991 as 359, with 1,656 relevant donations identified. If we go down further on this page, we can see number of recipients identified by the hospitals, 878. Recipients followed up, 701. Just pausing there, why do we have a gap of between 878 and 701 as between the recipients identified and the recipients followed up?
Depends what followed up means, and I can't remember off the top of my head. I presume that means actually seen and retested. No, that can't be true.
We then have the numbers of the recipients testing positive, 133, and the number of recipients testing negative, 70. That might suggest, Dr. Gillon, that only 203 of the 701 were tested.
Well, the number of recipients who died, they plainly followed up. The bottom column. What's puzzling me at the moment is if you add together the number of recipients testing positive and the number testing negative, you get to 203. You add that to 535, that's 738. But it doesn't, it seems to be rather more than the number of recipients followed up. So where do the extra deaths come from? That's what I don't quite understand.
So my reading had been slightly different, which was that the number of recipients who died, that figure should be added to the 878 recipients who, well, anyway. Dr. Gillon, can you assist us in any way of how these figures came to be reported in this way?
The only excuse I can offer is that the look back was always in a state of flux, and there were always things coming in and things going out. It's not perhaps a very satisfactory way to end that period of the look back, because I think these were the final figures when we wound up the official look back in 1998. Or they may have been interim. But whether it was final or interim, there would be stuff coming in and maybe not recorded yet in the final totals. I could have, excuse me, I might have been getting the feedback piecemeal from the various regions.
Dr. Gillon, I want to take you to one final document before we break, and that is PRSE 40881, please. It's a document from Transfusion Today, published in June 1999. It's not, you've said, it's not a peer-reviewed journal, it's more of a newsletter. Is that fair?
That's correct, yeah.
And if we turn to the next page, we have a note written by you, and it's quite long, but I'm going to read it out for the benefit of those who are watching. And then I'll ask you a question about it, Dr. Gillon. You say this: the question we've been asked, whether HCV look-back was worthwhile, is not for us to answer. Ask the patients, as I have done, and you get an unequivocal yes. They certainly feel that they have the right to the information, primarily so that they can seek treatment, but also in some cases to allow them to seek compensation and possibly revenge through the courts and from government. What right have we to withhold it? That said, the more interesting question that arises is why did it take so long? Was it because there was no treatment available? No. Interferon was shown to be beneficial in trials of treatment of NonA, NonB hepatitis before HCV was identified, and the antibody test very quickly established that NonA, NonB equals C. Though unlicensed, interferon treatment was therefore available. Furthermore, the fact that HIV lookback was instituted from the beginning of routine testing, when no treatment of any kind was available, suggests that in the case of HCV, the treatment issue was a red herring. Was it then the uncertainty about sexual and vertical transmission that held us back? Although less efficiently transmitted by these routes than hepatitis B or HIV, it was quite rapidly confirmed that heterosexual transmission is not uncommon, and indeed most transfusion services quickly decided that sexual partners of HCV-infected individuals should not be allowed to donate. Vertical transmission was also shown to occur, an important consideration in young female transfusion recipients, especially those transfused perinatally. Then it must have been about money, surely. There is no doubt that lookbacks are time-consuming and difficult. In reality, however, very little in the way of new resources has been committed to look-back programmes. You then discuss that point, and you carry on at the bottom of this column. What then was really going on? Why did the Transfusion Committee in different countries decide not to carry out look-back as soon as antibody testing was introduced, only then to perform a volte-face so late in the day, when logistical difficulty had been heaped on logistical difficulty? And what can we learn from it all? I think that the problem was one of psychology rather than logic. Lookbacks are difficult to manage and very unsatisfactory in terms of outcome. The process takes forever. Much of it has to be delegated to busy individuals outside the service whose good opinions we cherish. It's incredibly difficult to keep tabs on all the data. The whole thing seems very retrogressive when everything else in transfusion medicine is tending towards cleaner process control and increasingly hands-off management. We instinctively shy away from our messy pasts, just like some of our donors who say it was all so long ago. And most significantly, no one relishes the task of telling patients that they were harmed by the interventions that were meant to help them. In reality, at least in the UK, the profession did not make the about turn voluntarily. We were forced into it by a combination of peer pressure in the form of published articles showing that the process was feasible, patient pressure, and crucially, burgeoning media interest. It was largely fortuitous, but extremely convenient, that the decision by the government to recommend look-back in 1995 coincided with the licensing of alpha interferon for this indication. The most important thing we can learn from this is that such procrastination should not happen again. When we administer the transplant that a blood transfusion really is, we must accept the continuing responsibility for the medical consequences of that intervention without limit of time. Anything else that comes out of the exercise in a global sense, knowledge of natural history, epidemiology, treatment or whatever, may be extremely valuable and will have an impact on the cost-effectiveness equation. But this will take time to emerge. These aspects, however, must not be allowed to cloud the essential ethical issue, which is about the responsibility of an individual doctor to an individual patient. Dr. Gillon, that's what you wrote in 1999. Are they still your views today?
Well, I clearly had my journalist hat on that day. But yes, these are exactly the views I would express now. And the last statement about individual responsibility to an individual patient is exactly the way I felt about the situation when I got that letter from John Cash. So yes, I stand by all of that.
So those are the questions I have for Dr. Gillon. It's also perhaps a convenient time to break in any event.
Yes, well, Dr. Gillon, at this stage we'll take a break, but the reason for not concluding straight away, since Ms. Fraser-Butlin has finished her questions to you, is that there may be other questions, because core participants in the inquiry have been listening remotely. They will, I have little doubt, have some questions which they will ask counsel to put to you, and we must give them an opportunity to put those questions forward and a sufficient break. Do you have any sense, Ms. Fraser-Butlin, how long you might need?
I would have said half an hour, sir.
Half an hour, very well. So we'll take a break for half an hour. I can't tell you quite how long you'll be after the break. It could be a short while, it could be longer. It depends how many questions there are. So it's not really in my direct gift. But we'll come back then at 20 to 4. 20 to 4.
Thank you.